So we'll be discussing bladder pain syndrome and uterine artery embolization, two important topics. So, what is bladder pain syndrome? It is when a patient complains of pelvic pain, pressure, and discomfort related to the bladder and any other urinary symptom. And the duration should be 6 weeks to 6 months. And you have to rule out, it is basically a diagnosis of exclusion. It is after ruling out any other organic cause. The urine culture is sterile and there are no cystoscopic findings.
Okay.
So it is basically anything related to bladder, but whenever you evaluate, you do not get anything positive.
So culture will be negative only.
Everything will be negative. So it's basically a psychological thing, like irritable bowel syndrome,
Okay.
bladder pain syndrome. Okay.
Okay.
Okay. Then it is associated with negative cognitive. Obviously, when the patient is having pain and there is no relief, so there'll be some psychological symptoms like cognitive, behavioral, sexual, or emotional consequences, as well as symptoms suggestive of sexual dysfunction. Patients with bladder pain syndrome can have low self-esteem, sexual dysfunction, and reduced quality of life. Now, how will you differentiate between bladder pain syndrome and interstitial cystitis? In bladder pain syndrome, when you do the all investigations will be normal. In interstitial cystitis, you will find cystoscopic and histological features which are positive. So, a bladder pain syndrome is suprapubic pain related to bladder thinning, accompanied by other symptoms such as increased uh, day, daytime and nighttime frequency in the absence of any identifiable pathology or infection.
So it pain is related to bladder filling. So there won't be pain when there is a empty bladder.
Yeah.
Okay.
So basically, it's basically a psychological thing. It is nothing. There is no organic disease. It is a cycle like irritable bowel syndrome. So it is also psychological. This is also psychological. Now here, pain is mostly reported at sites are bladder, urethra, and vagina. And the patient, the degree of pain ranges from pressure and aching to burning sensation. It relieves after voiding. Voiding was found to relieve the symptoms in 57 to 73% of the patients. So they give you a scenario that voiding relieves the pain. They should click that it's a bladder pain syndrome. Okay, and it is aggravated because it's psychological. So there are things which can aggravate it, like stress can aggravate it, sexual intercourse, cognitive, constrictive clothing, acidic beverages, coffee, spicy foods, worsen with bladder filling and improves with voiding. Okay, understood.
Yes, ma'am.
Okay, so how like if a patient comes with this kind of symptoms, like if a patient comes with any urinary symptoms, also we'll be studying in neurodynamics. You have to ask them to make a bladder diary, and bladder diary is usually made for 3 days. So this question will also come in neurodynamics also. So you ask them to make a 3 day full bladder diary with input and output, and a food diary, like to see if any food is aggravating it. Urine should be done. Urine dipstick should be done to rule out UTI, as this is a prerequisite for the diagnosis of BPS. You have to rule out urinary tract infection. And investigations for urinary urea plasma and chlamydia can be considered in symptomatic patients with negative urine cultures. Suspicion of urological malignancy or persistent microscopic hematuria or urinary cytology should be tested. So in those you have to, if you are suspecting any malignancy, like if the patient is complaining of hematuria, then you have to do cytology, and if that comes out to be positive, then you have to do cystoscopy and referral to urology.
Okay, we are ruling out this bladder pain syndrome.
Yeah. Then, how do you rule out infection? You have to do a dipstick and a culture sensitivity test. But sometimes infection can be missed. Like you can get sterile pyuria in cases of uh, AFP bacillus like tuberculosis, urinary tract stones, partially treated UTIs, carcinoma in situ of bladder, and urea plasma. These are not routinely detected on the culture test, so you have to specifically look for them.
Okay.
Now, there is a classification based on the cystoscopy and biopsy findings. Although cystoscopy is not required for the mandatory for the diagnosis, but in case you do cystoscopy and biopsy, and you can grade based on these findings. Okay.
Okay.
So, if cystoscopy is done and it is normal, okay, then it is 1. It is 1. And if you do biopsy also, and if biopsy is not done, then it is cross or x, 1x. Okay. Then it is easy to remember. If you see, if the biopsy is normal, then 1a, inconclusive 1b, positive 1c. Okay.
Okay.
I'll be telling you what glomerulations and Hernot lesions are in subsequent slides. So in case glomerulations are there, then based on it is 2 then, and based on biopsy not done, normal, inconclusive or positive, it is X, A, B, C. So they can give you a scenario and they can tell that patient had pain which was aggravated, which was relieved on voiding, aggravated with stress. You did cystoscopy and biopsy, and you found Hannah lesions. So what is the stage?
Okay.
According to this, what is the stage? Huh?
Once again, come.
Patient with complaining of pain, which is aggravated, like on stress
Okay.
and relieved on voiding.
Okay.
You did cystoscopy along with the biopsy, and it showed Hannah lesions, and the biopsy was inconclusive. So,
3B.
yeah, it is 3B. So, like this, you can get on your you can get questions on the stage. Okay, so glomerulations, these are present in grade 2 to 3, uh, which is severe as of submucosal. These are basically submucosal spots, bleeding spots. And grade 3, diffuse bleeding of the mucosa, those are called as Hernot lesions. So Hernot lesions can occur with or without glomerulations. And positive biopsy, what are the biopsy findings which you can see? You can see inflammatory infiltrates, and or diffuser mastocytosis, and or granulation tissue, or intrafascicular fibrosis. So all these things can be there.
Here, the difference between normal and not done is not done means it's not done.
Yeah,
Okay. Normal means like after being done, there is
and
no finding.
yeah,
Okay.
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 So what are Hannah lesions? Hannah lesions, these are non-trigonal ulcers which are related to bladder epithelial damage, and these are seen like if you just put a cystoscope, you don't see them. They're seen only after hydrodistension to 80 to 100 centimeter of water pressure for 1 to 2 minutes, where the glomerulations must be diffuse and present in at least 3 quadrants of the bladder at a rate of at least 10 per quadrant, and not along the path of the cystoscope, as they may be an artifact. Hunner lesions may be seen as inflamed fibril areas or non-blanching areas in the non-chronic stage. These are seen in 11.7% of the women, and absence of Hunner lesion does not rule out BPS. And these are present in type 3 BPS and can be associated with reduced bladder capacity.
Okay, so it is seen within the bladder only.
Yeah, so I'll tell you how it is.
Type of ulcer.
Yeah, so these are like these ulcers which you see, that these bright red spots that you see. And glomerulations are like this, basically like a glomeruli of the kidney. So these are like network like vessels, prominent vessels you see.
Okay.
Okay.
Okay. So when these are present, then how are we saying it as a psychological condition?
Um, because it is like there is no gross. This is like this you see, not completely psychological, but there are no significant findings also, and it is aggravated by psychological things like stress,
Okay, okay.
sexual intercourse,
If
all
ulcer is
that. Okay. Then how do you manage it? First line is conservative treatment. Second line is pharmacological, then intravesical treatments and other option. So conservative treatment, you ask them to modify their diet, like avoid caffeine, alcohol and acidic foods and drinks should be considered. Like IBS is also not completely psychological. There are symptoms of constipation, diarrhea, all that. Okay. There is something which is irritating, but like you are not able to find that organic cause.
okay.
Same thing with this. Okay. The other thing is stress management, which may be recommended, and regular exercise can be beneficial. Analgesia is recommended for symptoms of pelvic or bladder pain, and limited data on benefits of acupuncture. Then pharmacological treatments, because it's a psychological thing, so you give SSRIs, oral amitriptyline, cimetidine can be considered as first line. Cimetidine is not licensed to treat bladder pain syndrome and should only be commenced by the clinician specialized to treat this condition. And the adverse effects of amitriptyline include dry mouth, constipation, sedation, weight gain, and blurred vision. Then there are certain second line treatments like intravesical treatments, which include intravesical injection of lidocaine, which acts by blocking the sensory nerve fibers in the bladder. Then intravesical hyaluronic acid, intravesical injection of botulinum toxin A, intravesical dimethyl sulfoxide 50%. The side effects of this include garlic-like taste and odor on the breath and skin, and bladder spasm. Full eye examination is needed prior to starting treatment, and 6 monthly blood tests for renal, liver, and full blood counts are advised. It is not again not licensed. Then intravesical heparin and intravesical chondroitin sulfate. Just a second. Hello, हाँ जी. Hello.
Yes, ma'am.
Sorry, I got a call from the hospital. Yeah. So other options include you involve the multidisciplinary team. Then, if Hana lesions are there, it is stage three. Then you can do cystoscopic fulguration and laser treatment, and transurethral resection of the lesions can be considered. You
Okay.
can also use ND-YAG laser under cystoscopic control. Neuromodulation in the form of posterior tibial and sacral neuromodulation can be done. So all this can also be done. Oral cyclosporin A can be given. It has adverse effects like hypertension, gingival hyperplasia, facial hair growth. Cystoscopy with or without hydrodistension. Uh, if you do, bladder rupture is a possible complication of prolonged distension of the diseased bladder, and hence low pressure distension is advised. And major surgery is considered as a last line treatment in refractory BPS.
What
So
is that major surgery?
sorry,
What is that major surgery?
you remove that affected part where a lot of Hanna lesions are there.
And like, what are the stages? You said in stage three, fungus lesions are there.
I told you, no, stages, stage 1, 2, 3 here. Hanna lesion is stage 3.
Okay, then stage two is glomerulation.
1 is normal.
Okay, stage one is normal. Okay. Okay.
Okay. Neuromodulation, where you stimulate the nerves, you do posterior tibial nerve stimulation or sacral nerve modulation. In posterior tibial nerve stimulation, a fine needle is inserted 5 centimeter kephalate from the medial malleolus and posterior to the margin of the tibia at the site of posterior tibial nerve. And this usually takes, you do it weekly for 10 to 12 weeks. And sacral nerve modulation, it involves an initial test phase with insertion of a test lead tunneled under the skin, which is transmitted into the nerve roots exiting the S3 foramens, causing stimulation of pelvic and pudendal nerves.
Okay.
Then major surgery, which is the last resort, where you do total cystectomy and urinary diversion in the form of supratrigonal cystectomy with bladder augmentation or bowel or supratrigonal cystectomy and orthotic new bladder formation with likely need of intermittent self-catheterization, and patients must be aware of the likelihood of persistent pain and pouch pain post surgery also. Okay, so this is the major surgery where you remove the bladder, and either you remove it completely or you remove it partially. If you remove it completely, then you either divert the urine, like you attach the ureter to the ileum, you create an ileal conduit, or you create a new bladder.
Okay.
So all that, but you have to tell the patient that pain can still persist.
Okay.
Urinary diversion in the form of an ileal conduit will not require intermittent self-catheterization.
Like endometriosis.
Yeah. So first line treatment, this is just a summary of what we have done. First line treatment is conservative analgesia, stress relief, dietary modification, exercise, physical therapy, support groups. Treatment fails, then you go for second line where you give SSRI like amitriptyline or cimetidine. Again, if the treatment fails, you refer them to MDT, pain team, clinical psychologist. Third line are intravesical. In the bladder, you put everything: DMSO, heparin, botulinum A, lidocaine, chondroitin sulfate, hyaluronic acid. Still not relieved, then you do neuromodulation or oral cyclosporin A. Fifth is this cystoscopy and surgery. The cystoscopy and hydro dissection, or this major surgery, and refer to tertiary center. Okay. Then treatments that are not recommended. So sometimes they can give you options that all these are treatment for bladder pain syndrome except. So you also have to remember this because these questions have been asked. So oral hydroxyzine is not a treatment. oral intravesical pentosan polyphosphate. So there are so many this hyaluronic acid, heparin, which we are giving intracyclically, but PPS we are not giving. PPS is thought to repair the damaged gag layer, which acts as a protective mechanism for the bladder mucosa. It has adverse effects of diarrhea, vomiting, rectal bleeding, and alopecia. In view of this adverse effect profile, it is no longer recommended as treatment for BPS. Long-term antibiotics are not recommended. Intravesical resin ferratoxin is not recommended. Intravesical BCG is not recommended. High pressure, long duration hydrodistension is not recommended. So you give pressures only this much, 80 to 100 centimeter of water over more than 10 minutes. Like you less than 10 minutes, you do not you give only this much pressure for less than 10 minutes, because if you
Okay.
give
So
more
it's
than
not
that
more than
it
10
can,
minutes. Mhm.
yeah, if you give more than that it will cause sepsis and bladder rupture.
Okay.
Some oral glucocorticoids are also not recommended. Now, role of MDT, whom all do you involve? Physiotherapist, pain team, clinical psychologist. Referral to psychotherapist. Bladder pain syndrome symptoms may be improved with physical therapy, like internal massage, which releases the pelvic floor from painful trigger points and areas of myofascial tenderness or restriction. Refractory bladder pain syndrome, you can refer them for psychological support or counseling if it is impacting on the quality of life, and patient request for a referral. MDT, refractory BPS, in order to explore alternative treatment options, and those patients who may benefit from neuromodulation should be referred to an MDT treatment before the to the MDT before the treatment is commenced.
Okay.
So before neuromodulation, you have to refer everybody to NDT. So this is again the same thing. This we have already studied. Then, if bladder pain syndrome is diagnosed in pregnancy, how do you manage it? So effects of pregnancy on the severity of BPS symptoms can be variable. BPS treatment options are that are considered safe in pregnancy. This is again a question. Include oral amitriptyline and intravesical heparin. So these
Okay.
are the two things which are safe. Although one course of DMSO can be used prior to the pregnancy for symptom remission with good pregnancy outcomes, it is DMSO is known to be teratogenic in animal studies. So it is during pregnancy you should not give DMSO. Prior to pregnancy you can give one course.
What
Okay.
are you giving? No. Prior to pregnancy?
Prior to, if the patient is planning for pregnancy and she has bladder pain syndrome, you can think of giving one course if she's not getting relief with the other things. However, during pregnancy, because it is teratogenic in animals, so you do not.
Okay.
Okay. Unless the pregnant patient belongs to a family that has multiple members with the condition, she can be reassured that the risk for passing it to the child is very low.
Okay.
What all should not be given in pregnancy? Lidocaine, it does cross the placenta and there is no information about the safety, so you should not give lidocaine. Systemic corticosteroids, because they have long-term effects on hypothalamo pituitary ovarian axis and cause adrenal suppression in the baby, so again they should not be given. Absorption of intravesical corticosteroids is not known. Sacral nerve stimulator should not be placed during the pregnancy, and if already present should be turned off for the duration of the pregnancy, as the effect on the fetus is small.
Okay.
So only two treatments that you are giving it during pregnancy are for
Oral
this:
amitriptyline, IV heparin,
intravesical heparin.
intravesical. So only heparin, not okay.
Other.
Low molecular weight. Okay.
Okay. So this question.
Yeah. 58-year-old woman presents with 9-month history of painful bladder syndrome.
Bladder pain syndrome.
It's characterized by increased frequency, positive urine culture.
Next question.
Synthetic pelvic pressure discomfort. 6 story. Locations tissue. Okay, let's put this here. The option D.
Yeah, it is not should not be present along the
That
path.
may be artifact. Painful bladder, hemorrhagic spots. Interstitial cystitis.
Yeah, because cystoscopy, because they've not said on hydrodissection.
Okay.
If it was on hydrodissection, then could be Hanna's version, but otherwise, like that only. Also, if hemorrhagic spots are there, then it is.
If Hannah's lesions are present, will there be hematuria?
No, usually no. Okay. Then this question.
Diffuse abdominal pain, generally smooth. Post embolization.
Yeah, it is post-embolization syndrome. So 40% of women have a variety of symptoms and signs post-embolization, including diffuse abdominal pain, generalized malaise, anorexia, nausea, vomiting, low-grade fever, and leukocytosis. It's a self-limiting syndrome and usually resolves within 2 days to 2 weeks. Usually, you just have to give supportive treatment with intravenous fluids and adequate pain control, including NSAIDs and anti-inflammatory drugs, which is appropriate. Then this question.
40-year-old asymptomatic fibroid
Yeah, you do not do this thing
or asymptomatic
for
fibroid.
asymptomatic fibroids. So uterine artery embolization is indicated in women with symptomatic fibroids, causing
Okay.
bleeding, dysmenorrhea, pain, dyspareunia, and pressure symptoms.
Irrespective of the size of the fibroid.
Yeah. It can be used in women with adenomyosis, although it is reported to be less efficacious. Women should be counseled appropriately. If the surgery is contraindicated, example in Jehovah's Witness or women who had previous unsuccessful surgery of fibroids, uterine artery embolization can be considered. Absolute contraindications include if the fibroid is asymptomatic, or if there is recent or current infection of the genital tract, or if there is pregnancy, if the diagnosis is uncertain due to clinical feature factors or inadequate imaging, when a patient declines hysterectomy due to social or cultural reasons, even after appropriate counseling. For example, like small proportion of the patients need hysterectomy following uterine artery embolization also,
Okay.
because of the infection. Sometimes the infection can be very bad, demanding hysterectomy. The patient, whenever you are counseling the patient for uterine artery embolization, you have to counsel about infection and possible need for hysterectomy. The patient doesn't want it, you cannot go for this thing also. Relative contraindications include narrow stalk pedunculated submucosal fibroids, because it can get detached and block the cervical canal. Large intracavitary submucosal fibroid may result in sloughing of the fibroid and cause cervical obstruction and occasionally sepsis. So pedunculated, either submucosal or subserosal, you do not do it. Pedunculated subserosal fibroids may again detach from the pedicle and may need laparoscopic removal. If the woman wants to preserve fertility and has symptomatic fibroids, then also you do not do it, because it has been seen after uterine artery embolization, ovarian failure can occur in 1 to 2% patients, although more common in women who are more than 45 years and those nearing menopause.
Okay.
Then post uterine artery embolization, if the patient conceives, then there are increased chances of cesarean section up to 80%, increased chances of preterm labor and delivery rate up to 20%.
Mm.
Only one third of the patients deliver vaginally.
Mm.
There are increased chances of malpresentation, increased risk of PPH,
Mm.
increased miscarriage rate in patients with UAE for fibroid. Then, if the female's untreated for fibroids.
How cesarean is increasing?
That we, because probably the blood flow is less, so baby blood flow is also compromised. So IUGR, all that thing occurs, and so
Okay.
maybe cesarean.
Okay.
These are all research things that they have found, probably because of that.
Okay.
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 Then a risk for further treatment for patients less than 40 years, as there is more than 20, uh, risk for further treatment for patient less than 40 year, more than 25% by 5 year, and if the age is 40 to 50 years, the risk is 10%. So this means that need post uterine artery embolization also some patients might need additional treatment. If they are
Okay.
young, less than 40 years, then more than 25% by 5 years. If they are 40 to 50 years, then it is around 10%.
Okay.
And further treatment may include hysterectomy, myomectomy, and or exploration of the uterine cavity. Permanent amenorrhea is seen in 1.5 to 7% of the patient, and urgent hysterectomy due to infection is seen in 1%. Minor complications include vaginal discharge, puncture site bruising, which is seen in more than 20 to 30% cases. Okay. So
What is that acceleration of the endometrial cavity? Why?
exploration of the uterine cavity, if there was a pedunculated submucosal fibroid or if there is any infection sepsis, so then you might need a further treatment
Oh,
after uterine artery embolization.
okay.
Okay. So now coming to your doubts.
Yeah. And the last one which I have sent, actually answer seems to be option D only.
C.
C.
Yeah, it's C,
They-
because medical treatment,
mm,
it cannot improve. What is a medical treatment for endometriosis?
Actually, the following are true except, so they are asking for the
Yeah.
false statement. Medical treatment of laparoscopically diagnosed, yeah, it will not improve. Only surgically it is corrected. And what is the last option? Surgical excision of mild to moderate endometriosis has poorer outcome. It has better outcome only, no?
For severe, it has. Mild to moderate, you can leave it and do COS plus IUI or ART also.
Okay, so it means that for mild to moderate,
When you are removing the endometriosis, you are also damaging the normal ovary, and it
okay,
has a
so
ovarian reserve.
okay,
So,
so surgery is reserved for severe cases.
yes.
Okay, option C is correct. And in option B, laparoscopic incision of endometriosis with drainage and irrigation is associated with low morbidity and poor long. That means like excision is better rather than incision.
No, excision is better, but even if you are doing incision, it will also improve, although recurrence can occur. So, the best option here is C only.
C only. In B, they
Because
are saying
medical
like it has poor result only. So, okay, logically, the
Are
options.
contraceptives only. You give either GnRH agonist, which will affect like the patient cannot conceive. Dynogest is again a contraceptive. OCPs. So you never give medical management for patients who are trying for conception. There is no.
Okay, so also like it means that surgery is for severe cases. Mild to moderate, we can try with intrauterine insemination.
Yes.
Okay. And this one, another previous one, Turner syndrome undergoing oocyte donation should be counseled that they face higher risk during pregnancy. Why is it with the oocyte?
Turner syndrome is associated with coarctation of aorta, no?
Okay, like so it means that
Right.
even with their own oocyte or even if it is the donor.
The pregnancy is high because of the
Like pregnancy itself, high risk pregnancy. It's not with the
no, no.
oocyte
It's
donation.
with a donor. So
Even with
it's
okay,
very difficult to conceive
okay,
unless
like
there are mosaics.
okay, like so we have to inform them pregnancy itself high risk. It's not about their egg or donor. So it means that. And recurrent pregnancy loss. So recurrent pregnancy loss is two or more. It's not three or more.
It is two or more. The previous definition it was three or more.
Now it is two or more.
Or more, yes.
Okay. And this question, ma'am, which I have, which is the correct option here? They are saying by definition.
So that this is
So this
probably
is old.
good. Uh, B is also wrong.
B is wrong only. Yeah, like correct is C. This is according to older guideline.
Yeah.
Yeah, A and B both are wrong.
Yeah.
Both are wrong only. It's marked wrong actually, right? They are
All
asking for
are
the.
wrong except which is true they are asking.
Yeah, they are asking which is true. Which is true here? That option C is true.
Because that is the most true. It is according to the old definition.
Yeah. A and B are interchanged actually. Definitions are interchanged. He- Like C is the correct option, but they are showing us B, which is actually wrong. Marking itself wrong, right? And so from in this figure scoring, from end of index pregnancy means the previous one.
Yeah, so previously if she
What,
had conceived
what
or if
it
she
does,
had a
whether it's a delivery or an abortion or whatever.
yeah, yeah, end of that, yeah.
End of that means the end of that
Delivery or
delivery
abortion.
or abortion, whatever. To treatment. To treatment means initiation of treatment.
Yeah.
Okay, that period. And this corneal pregnancy.
Sorry?
No, no, this corneal pregnancy.
Hormone pregnancy. What?
The is of single interstitial portion of the tube. You don't realize symptoms. What is the difference between corneal and interstitial pregnancy? Corneal ectopic means it will be in the sac will be in the cornua.
Interstitial means it will be in the interstitium. So this tube is divided into various regions.
Yeah.
It is cornua, which is the closest to the tube. Then there is interstitium.
Okay.
Then there is ampulla, and then there is fimbria. So based on the part which is involved.
So treatment remains same only for both.
Yes.
Like how to choose a corneal resection or salpingotomy in interstitial pregnancy.
So if the corneal resection,
Depends on the options.
I don't think you will get options like that. Did you come across any question?
Usually in interstitial pregnancy, what do? We go for salpingotomy. Because I think there was an option, corneal resection. I don't remember.
So both of them are corneal resection and salpingotomy. How will you resect the cornea? By giving an incision on this tube, no?
Mm-mm.
Both of them actually mean the same only.
Yeah. Here,
Or you resect the cornea and restitch the remaining tube with this thing. That is partial salpingectomy, like that.
left. Okay, the leftover tube. And what is this one? In this thing, amniocentesis, is it's 30 or 20. More than 30 ultrasound guided invasive procedures are done by because like in one question the answer was 30 and in another question the answer was 20.
This I'll check and let you know. I'll
Yeah.
also check. What is in
Actually,
the
under there was one preparatory video on amniocentesis. It was mentioned as 30 in that in study medic, but answer was 20 in another question.
I'll check.
Okay, and this one you sent no abortion classes.
That I sent.
Yeah, E for excessive bleeding. E is actually
E is when child is at risk of any physical, mental, or seriously thought to be seriously handicapped. There is
down.
potential risk to the baby. F is to say save emergency.
Emergency, okay, to save the life of the mother in emergency situation. And down it's mentioned as E as excessive bleeding. What it is?
Excessive bleeding again because the like if there is excessive bleeding. So this I mentioned from a question. So there was one question where they had asked the patient has excessive bleeding.
Mm-mm-mm.
Uh, Abortion will be done under what clause? Because if she's a mother's life is not at risk here because the bleeding will be less. Like
Okay.
it can be managed like with blood and all that. But here the child born will also not be healthy. So there the answer was clause E. So that's why I had put.
Okay, okay. So, okay, this was about the baby here.
Yeah, because the baby also won't be healthy.
Okay.
This was from one of the recalls, I think. So
Oh,
that's why
okay.
I put it there.
And heparin. So, like they have mentioned as a heparin is not. It doesn't have evidence in inherited thrombophilia. So we are going for low molecular weight heparin only.
Only for APLA you give low molecular weight heparin.
Okay.
For other thrombophilias, heparin has no. Only for APLA
Wait.
positive.
Okay. So for APLA, low molecular weight heparin, and for thrombophilia, we are giving heparin.
You always give only low molecular weight heparin. Thrombophilia, there is no role. That's what I think it's written. Only for APLA, low dose
APLA
aspirin.
itself, it is acquired thrombophilia only, right? What do they mean here actually? Insufficient evidence on these following.
For thrombophilias, heparin
Mm.
has less role. Like there is no evidence. Only for APLA, heparin has a role. You
Okay.
always only low molecular weight heparin because other unfractionated heparin, there are other side effects. It is short acting. You have to give it every 6 hours. Second,
Okay.
associated with heparin-induced thrombocytopenia. It does causes this osteoporosis. So you do not,
Osteopenia.
yeah, you usually always use low molecular weight heparin. So by
Okay.
the evidence, you have substantial evidence only for APLA positive. For other thrombophilia, like there is limited evidence.
Limited evidence of heparin.
Yeah, that you have to give.
So in inherited thrombophilia with recurrent first trimester miscarriage, it means that heparin has limited evidence.
Yeah.
So better to go with LMWH. Okay. And this one, ma'am. Hmm. Chance of a healthy live birth in untreated pregnancy is 50 to 70%. After IVF is 30 only. How?
That is natural, no, when everything is fine.
Mm,
Who will go for IVF if something is problem, right?
okay.
So uh, if she's conceiving naturally, like overall in the
That
entire
itself is
population,
here.
natural pregnancy, 50 to 60% there is chance. But for this IVF, it is 30%. But I think
Even with
there,
donor gamete, it is less only.
yeah, 30%.
Have to just remember all these percentages. And this thing. What is the difference between pregnancy of unknown location and persistent pregnancy of unknown location?
Have you shared it with me?
Yeah, I have.
I cannot see.
I'll share it. I'll share it now.
Pregnancy patient is where you do not know there is nothing like persistent pregnancy of unknown location.
Mm.
Term like that. It is
So
only pregnancy of unknown location.
okay, because there was a patient and the option was persistent pregnancy of unknown location.
There is no
I thought if the HCG is doubling means we can take it as persistent pregnancy. Not like that.
there is no
Because if the HCG is 1500, we'll definitely see a sac, right?
ideally we should, but we are not able to localize for we just somewhere outside.
So there is no term such
Persistent.
persistent pregnancy of unknown location. Even if there is an option, we should go for pregnancy of unknown location only.
Yes.
And this thing, what is genetic screening showed a paternal balanced translocation. What is the chance of having a healthy baby? Hmm? When they have a balanced translocation, like how there is a chance of 80% of having a healthy baby.
So this is not autosomal recessive or dominant. It is not inherited that way. So
Mm.
it has been seen. So this is based on the evidence that they have given. So this is a line from the guideline. That
Okay, so
it is
okay,
not like there is no inheritance like autosomal dominant or sex linked for translocations.
so it has been
Just
taken from the guideline only.
have to remember this
Okay,
percentage.
it's like a statistic.
Yeah.
Okay, and this thing, vesicular mole. This
Hmm.
patient is coming with presenting with heavy vaginal bleeding and crampy period-like pains at 10 weeks of gestation. She has been passed this tissue, and her cervix is still open only. What do we do? We are doing suction evacuation.
Yeah.
So, so when is oxytocin used only in life-threatening hemorrhage?
No, you never use this thing in molar pregnancy oxytocin.
Okay, like
Only
in
after evacuation because
mm,
it will cause invasion of these trophoblastic tissue into the blood, resulting in increased chances of GTN. So you do not do that.
we do not use at all,
Molar
except
pregnancy, you only do evacuation, suction
yeah,
evacuation.
yeah, like usually evacuation only. Oxytocin is the last resort, like in life-threatening hemorrhage,
Not controlled, then you use it. Yes.
just to save the life of the mother.
Yeah.
So question should be something like an emergency.
Yeah.
Okay, like whatever pain
You
or
start oxytocin only after suction evacuation is complete.
okay, okay,
Because
so
once you remove the tissue, anyways, the bleeding is going to stop.
okay, so okay, that will be last only. And, uh, so whenever in question when the contralateral tube is not mentioned, we should go for salpingectomy only.
Yeah. Because there are increased chances of recurrence of ectopic also.
And in another question also, like that was class F only, I think, but it was given as this one. I just shared that with you now. I've shared one now. A 41-year-old woman attends her midwifery care. She has had three previous normal deliveries. Last one 5 years back. She is currently 28 weeks pregnant. There is no significant history. She's have no. Like for this and all, we don't terminate. No, this is not a reason at all.
24 weeks you cannot terminate if there
Uh,
is no
she is
reason.
28 weeks.
Yeah.
So,
So
so like, okay, it will not fall under any clause.
yes, you will not. You cannot terminate.
But, but there are two clauses, no, which we can terminate even after 24 weeks.
But emergency EMF.
Only E and F.
Yes.
The rest within for 24 only.
Yeah.
A 26-year-old woman has presented to accident and emergency with a bleeding per vaginum, and her observations are suggestive of hypotensive shock. So this is emergency case only, no? So this comes under clause F. Hmm?
Which question?
I'll share it again. Last one, no. She is 12 weeks now. On examination, there is ongoing bleeding with deteriorating
This is
maternal.
again same one, no, which I showed
Hmm?
you. Excessive bleeding. E. So this was again the recall, no. So that's why I had put that
So,
there itself. Excessive.
oh, okay. So this is class F only, right?
This is clause E, no.
How
Excessive.
how it is E?
Because it will also affect the baby. Baby will not have if there is excessive bleeding means the baby will also not survive with this.
Mm-hmm.
So this was a recall and the answer was E only. So that's
This is
why I put it there also.
but here they are asking, they are saying decision for a termination to save the life of the woman is made. When they say it is for saving the life of the woman, then why not it comes under clause F?
Yeah, but then this was a recall, so that's why I had put it there. This was a conflictory thing, and the answer was E only.
Mm-hmm.
So this was a little.
Okay. Okay, ma'am. There
Anything?
should be a bit of luck. Oh, that's it.
Okay, thank you. Next class, we'll study about the benign ovarian lesions, pre-malignant cyst, post-malignant cyst, adolescents and children cyst, how to manage all that.
Okay.
Iota RMI.
Okay, ma'am.
Okay, bye.
Thank you, ma'am. Bye bye. Good night.
Good night.